As mentioned, I'm from British Columbia, and I'm running an enhanced recovery program within my own health authority. My health authority is about the size of Great Britain, and we have a total population of 272,000 people, so it's very widespread. We're very rural. We have some climatologic challenges in wintertime, so we can't just transfer patients easily. So we have to run our enhanced recovery on a wide basis. And I'm also running an enhanced recovery collaborative for the entire province through the Doctors of BC. This all started back in 1946, and my talk is probably going to be a little bit more about history and culture. It's going to be very little polluted by actual science and evidence. Dr. Mendelson published a series, his observations on about 14,000 operative deliveries. He was an obstetrician gynecologist, and he described the complication of aspiration of stomach contents into the lungs during obstetric anesthesia. This accounted for 0.15% of patients and a couple of deaths. As a result of this paper, which was a surgeon describing an anesthetic complication, we named the syndrome after him, to his lasting shame. And this strategy in terms of history and culture worked very well because there are few surgeons willing to describe anesthesia complications any longer. That's how you build a silo. But it's an important topic, respiratory failure secondary to aspiration pneumonitis, and its prevention has become a cornerstone of anesthetic practice. This involves hundreds of hours of teaching, tens of thousands of hours in writing papers, tens of thousands of papers, in fact, and a lot of committee work dedicated to developing guidelines for preventing aspiration pneumonitis. There's an interesting Canadian link to this. This poor gentleman suffered a gunshot wound to the left upper quadrant. His attending physician is Dr. William Beaumont, who was a military surgeon in the northern United States. This is Mr. St. Louis, who is actually, or was, a Canadian fur trapper. These two had an association. Dr. Beaumont operated on him. It was a grievous injury. He was not expected to survive. He did, but he survived with a gastrocutaneous fistula that Dr. Beaumont went on to study and come to understand a great deal about gastric physiology, well ahead of his time. And in fact, they worked together for about 2 years. It's interesting that Mr. St. Louis actually outlived Dr. Beaumont because Dr. Beaumont moved to a city where he slipped on some icy steps, cracked his head, and did not survive. The patient did better than the doctor. So out of the observations of Dr. Mendelson, we came up with some nil per os at midnight guidelines. And the objective here was to reduce gastric volume and acidity. We have an impression that there's an at-risk population. The data for that is based on studies in rhesus monkeys, unpublished work. But it basically asserted that if there was adequate acidity and adequate gastric volume, that the risk of aspiration pneumonitis went up. The trouble with this is that it's a very difficult area to study. It's very difficult to blind a patient to whether or not they're having anything by mouth, or to whether it tastes good or not, and to whether it's timed or not. So actually designing studies to study or to make meaningful sense of fasting regimens is problematic. Also, most of these studies have been conducted in healthy patients and in volunteers, and that doesn't always translate very well to the operating room. The consequences of a nil per os guideline is dehydration, thirst, nausea, and anxiety, all of which are amenable to changes in preoperative fasting. So I'm just going to ask for a show of hands, who in the room has fasting guidelines as part of their institutional practice? Very good. How many of you allow clear fluids up to 2 hours prior to the operating room? So I'd encourage everybody to look around. There are somewhat fewer hands going up, but still most. So these preoperative fasting guidelines, which developed out of tens of thousands of hours of committee work, I'm proud to say that the Canadian Anesthesia Society was one of the early proponents of this, thanks to the efforts, convincing efforts of Dr. Maltby in Calgary, Alberta, not too far from where I live. But the American Society, the European Society, and I apologize to anybody in the room whose society isn't actually showing up here, everybody's got fasting guidelines, and most of them are clear liquids up to 2 hours preoperatively, and a light meal or solid foods up to 6 hours preoperatively. So the question is, what does a clear fluid look like? Well, by definition, you have to be able to read the newspaper through it. So all of these would work. Obviously, this is a clearer fluid. This looks like a pint of pale ale, which, as you can see, you can read through it. It qualifies. How many people would allow water up to 2 hours? Good. How many people allow apple juice? Okay. It gets murky. Apple juice isn't always a clear fluid. You can't read through that, but I'll give you that. Would you allow this second apple juice? Very few people. Well, some. Okay. How about these? Very few people. It's common in Canada for people to be allowed fizzy beverages. How about this as a clear fluid? Again, more people would allow coffee than fizzy drinks. That's interesting. How about milky tea? Okay, a couple people. Now it's interesting, this article, just published recently, demonstrates that milky tea is actually, the gastric emptying time for milky tea is the same as water, provided that the milk doesn't account for more than 30% of the volume. I don't know why 30, why not 25, why not 50, but as long as the milk isn't more than 30%, you can have milky tea and gastric emptying will be the same. Here's some clear fluids you might want to consider. There you go. How many people would allow this? Not too many. It's really interesting. This is old stuff, but it's really interesting that a moderate alcohol consumption associated with a meal speeds gastric emptying. So maybe it's not a bad idea. I wouldn't recommend it. How many people would recommend this as a clear fluid? The problem, this actually happened in Alberta. Patients had been instructed to what they were allowed to take as a clear fluid, and one patient turned up having had a full banana, claiming that that qualified as a clear fluid. How many people would cancel the surgery for a few hours? Yeah, everybody, of course. That's good. So how are we doing in terms of compliance? So we've got these recommendations to allow clear fluids up to 2 hours prior to surgery. Are we compliant with that? The answer is largely no. This was a study published in 1996, performed in the earlier 90s, up to 92 to 94. The new NPO guidelines and fasting recommendations had been in place already for a number of years. And this was a survey of chairs of Department of Academic Anesthesia Departments and directors of ambulatory care facilities. And the response rate was 75% from the chairs, probably because they're funded to do this work, and only 57% from directors because they're not funded to do the work. 2/3 of these people had altered their NPO policy, but despite the fact that the NPO policy had been modified, still only 40% of people were going to allow clear fluids. So there's clearly a discrepancy between what we know is the right thing to do, or what is safe, and what we're willing to allow. And that goes on today. In fact, my colleague, Dr. Merchant, is presently conducting a very similar survey of Canadian anesthesiologists on a much wider basis than this to see whether attitudes have changed and whether clear liquids in the variety of forms are acceptable in Canada. I suspect there will be a reporting bias in favor of people who actually do allow it. We'll see. And here's the rationale for that. If you have a purely liquid meal, gastric emptying follows an exponential curve. A solid meal, there's a delay in any gastric emptying, and then it's an arithmetic decline. So it really does make sense to not allow solid meals. The question is, what constituents can we add to a liquid meal without it losing this exponential curve and behaving more like a solid meal and delaying gastric emptying? Well, it turns out you can actually add up to 12.5%. You can actually add up to 12.5% carbohydrate without affecting gastric emptying, provided that you keep the volume down. So 12.5%, 200 mils, just a little less than a cup, doesn't change gastric emptying time. If the mils go up to 600 mils, then the gastric emptying time is actually delayed. So 12.5% carbs is okay. What about the addition? What kind of carbs? So are these simple sugars as are present in fruit juices, cranberry juice, apple juice, orange juice, or are more complex carbohydrates acceptable? And it turns out the addition of maltodextran reduced gastric volumes compared to simple sugars. So maltodextran, complex carbs are very acceptable as part of a preoperative feeding regimen. The reason we're doing this is not just for patient convenience. It's not so that they're less anxious. It's not so they have less dehydration at the time. What we're really aiming for, and this should be an entire talk on its own, is to prevent insulin resistance. So insulin resistance is known, it's a graded response due to metabolic stress. The higher the level of stress, the more likely you are to see insulin resistance, and the worse it is. Even though your blood insulin levels are up, you still have hyperglycemia. The insulin isn't facilitating blood glucose getting into the cells. In fact, it promotes free fatty acids being liberated from cells, and because the energy substrate in the cells is no longer glucose and glycogen, there is catabolism resulting in the breakdown of muscle to generate energy. And pro-inflammatory cytokines are elevated as well. So insulin resistance is difficult to avoid, but it is the reason that we feed people prior to going to the operating room. And the benefits are, what you can do about it is do the carbohydrate feeding, and thoracic epidural analgesia will help with that as well. There's very little else we can do, but carbohydrate feeding alone will reduce the probability of insulin resistance by 50%. What's coming next will be something along the lines of tight intraoperative glycemic control, and that's not the topic of my talk, but that is part of the topic of insulin resistance. So, clear fluids are acceptable. The advice is be prescriptive if you don't want to end up with a banana as a clear fluid. Tell them what volume they can take, tell them when they can take it, and be very prescriptive relating to the time they're going to the operating room. That's the advice about fasting. I think I'm done. Oh yeah, there's one more. Pharmacologic measures to reduce the likelihood of aspiration pneumonitis. The evidence surrounding the use of antacids, prokinetics, and H2 receptor blockers is, there's a lot of studies. This has been a very fertile area for publication. The evidence is not absolutely convincing for any of these that it reduces the likelihood of aspiration pneumonitis. So, summary slide, suggestions. You can have solids up to 6 hours, fluids containing carbohydrates up to 2 hours, and that carbohydrate can be a complex carbohydrate up to 12.5%, and the total dose up to 2 hours should be about 50 grams to prevent insulin resistance. And we'll take your questions later.